Distributive shock will have general signs and symptoms indicative of its three subtypes: septic, neurogenic, and anaphylactic. In a thorough patient assessment, we will find many of the following clinical indicators.
During our initial patient assessment, we may notice that our patient's heart rate has increased to over 90 beats per minute. They may present with a bounding pulse, be tachypnic and having a respiratory rate above 20 breaths per minute. We also may see exceptionally low blood pressure, below 90 millimeters of mercury. They should also have some altered mentation or looking confused and possibly dizzy, as well as some decreased urine output as well. The extremities may still be warm, and if we're listening to their breath sounds, we should hear dull percussion as well as some possible crackles and rhonchi. Now, the possibilities for what causes this may include their skin being gangrenous, having ulcerations, rash, necrosis, and trauma indications. Now, of course, we're going to want to do a laboratory workup for the patient, or at least have one to access, and we'll see a complete blood count with a differential for this patient. We want to see what indications there are that there might be infection. There will also be a urinalysis done, as well as an electrolyte assessment. We will also check for blood urea nitrogen, creatinine, glucose, and as well as with that urinalysis, we'll have a urine and blood culture done as well. There may also be an arterial blood gas that's drawn, and of course serum lactate will be assessed, especially with metabolic acidosis or an elevated anion gap for that patient. In addition to these things, we'll have diagnostic testing that will be completed. Quite often an electrocardiogram, which helps us determine the underlying cause. And in this chest radiograph, you'll see here for this patient, there's increased densities in that right lung. And this is what chest x-rays do for us, allows us to see the degree and the extent to which we might have some infection in the body, especially in the lung. It's a great indicator for the lungs and pleural or pulmonary issues, excuse me. They also might use computed tomography or CT scans, and this is the test of choice for suspected intra-abdominal causes of sepsis. That includes appendicitis or any kinds of infections of those major organs in the abdominal cavity. Some patients may also need a lumbar puncture, and this is indicative if there's suspected neurogenic shock, especially if there's a possibility for meningitis or something like that that's affected the brain or spinal cord. And finally, patients may receive a transesophageal echocardiogram, and this helps us to assess preload and ventricular wall motion as well as the pericardium. This allows us to see possibly again what the causes are for the septic the distributive shock in the patient. That may cause them to be septic, but certainly to have some systemic, widespread inflammatory response that we're seeing evident either through their signs and symptoms, or their blood work, or through some of our diagnostic tools. Hemodynamic monitoring will occur jointly with the monitoring of vital signs, intake and output, etc. And if vasoactive drugs are administered, a central venous line as well as a pulmonary artery catheter should be considered and secured. Now, it is imperative that systemic vascular resistance and ventricular filling pressures, as well as systemic blood pressures, be monitored continuously for distributive shock patients. Now, let's look at our table again for distributive shock. When it comes to the effects of shock on the hemodynamic parameters we'll assess from our patient. If you notice here, the actual highlighted portion is blank because there's three subsets of distributive shock that they're analyzing. It's neurogenic, anaphylactic, and septic. So we're going to look first just at the overall trend that distributive shock patients tend to carry when we're assessing their hemodynamic parameters. So distributive shock, as I said, is neurogenic, anaphylactic, and septic. Often have decreased pulse pressures and blood pressures. They also have decreased systemic vascular resistance and often have increased pulmonary vascular resistance as well as decreased central venous pressures. There also may be decreased pulmonary artery wedge pressures and often decreased pulmonary artery pressures, cardiac output, and central and mixed oxygen saturations. Now, of course, for every patient, this may vary, but these are the overall general parameters we're going to see for our patients who exhibit signs and symptoms and have telltale signs of distributive shock. Now we're ready to look at some of the medical drug-related options we have for treating patients with some form of distributive shock. Now keep in mind, distributive shock has a lot of inflammatory responses that are being sent throughout the body that are often caused from some type of infection. So most of these prescriptive elements are antibiotics of some type, and a few are actually just therapies meant to help treat the actual allergic or inflammatory response in the body. So let's get started. The first drug we're looking at is nafcillin. This is an antibiotic that helps create an undesirable environment for bacterial systemic growth. The next one we have is called Fortaz, and this is a cephalosporin with a broad spectrum aspect. It helps arrest bacterial growth. There's also Levaquin, which is a multi-drug resistant gram-negative antibiotic. There's also ampicillin, which is an alternative bactericidal antibiotic to amoxicillin, especially if a patient has an allergy to that. The next one we have is clindamycin. It is a lincosamide that helps inhibit bacterial growth by blocking a specific peptidyl transfer of tRNA. That's the ability for the bacteria to actually reproduce. And this will help counteract some of that bacterial toxin release that happens from its replication cycle. The next drug we have is gentamicin, and it is an aminoglycoside antibiotic for gram-negative bacteria. The next is tobramycin, which helps treat staphylococcal infection and is very prominently given to cystic fibrosis patients. The next one we have is amikacin. This helps block bacterial protein synthesis, and the dosages for that one are based specifically on ideal body weight of the patient. The next one we have is vancomycin. This is a very potent antibiotic that fights gram-negative bacteria, and it's often used prophylactically in conjunction with gentamicin. The next one is erythromycin, and this one helps inhibit bacterial growth like the others, but it does so by blocking the dissociation of tRNA in the bacteria. The next one is azithromycin, and this helps treat mild to moderate microbial infections. The next one is called Zyvox, and this helps provide similar coverage to vancomycin. It's just an alternative method of doing so. This next drug is Zosyn, and it's just a broad spectrum, but it is not broad enough to cover a MRSA or methicillin-resistant Staphylococcus aureus infection. Okay, so most of those antibiotics are there to help treat the infection of some sort. And we also have what is also used as hydrocortisone creams, and this is a mineral corticosteroid for hypotensive patients, low blood pressure, that are poorly responding to fluid resuscitation or vasopressors. So whatever fluid bolus was given to help them build up some of their fluid volume in their body is not really working. We give hydrocortisone as well. We also have vasopressin, which is a vasopressor. It is also an antidiuretic hormone, and this will help increase the water retention in the body, so that fluid that we're giving is retained and the body is able to hopefully use some of that in the resuscitative efforts we're giving for the patient. And that vasopressin will also help promote smooth muscle retention. Lastly, we have is dopamine, which we talked about previously. Again, low dose. Stimulates renal and mesenteric vasodilation, and of course that little higher dose stimulates cardiac function. And finally we have norepinephrine, and this will increase cardiac muscle contractility and help increase cardiac output and help stabilize that blood pressure. So remember, for patients with distributive shock, that low blood pressure, we want the heart to keep pumping but not work too hard. We want to increase its ability to pump effectively. That wearing out all of our different systems, our immune system from fighting the infection, our cardiac system from trying to move blood, and our vascular system from trying to maintain integrity to pump effectively and have adequate pressures for perfusion and oxygenation and etc. So these are just some of the medicated drugs that might be used and commonly used and seen for patients that have some type of distributive shock. Remember, distributive shock is neurogenic, anaphylactic, and septic. So it's addressing some variation of all forms of those types of distributive shock.
Patients with distributive shock may often present with a metabolic acidosis, with a decrease in oxygenation and an initial lactic acid buildup. However, some types of shock release toxins that can induce fever in patients, causing an increase in respiratory rate and a drop in blood pH, thus respiratory alkalosis.